Mr. Chairman, ladies and gentlemen, first of all, I would like to thank the organizers for inviting me back to wonderful St. Petersburg. I also want to thank for those working on the slides and translating them in Russian. Whether it's correct, I cannot tell you. The important subject that I'm talking about is protease inhibitor-based triple therapy in patients with advanced fibrosis cirrhosis. So this is the third of 3 talks you heard. And I would like to give acknowledgement to the people that work with me in this area, and I also want to thank all the networks that we are part of. In the first talk by Mark Thurs, you heard the introduction of triple therapy based mainly on phase 3 trials for treatment-naive patients. Thomas Burke explained to you the efficacy in treatment-experienced patients. My task is to analyze with you the data available on cirrhotic patients. And we are here. And we only discuss genotype 1 patients. This has been mentioned before. And I think this is also important when I discuss with you cirrhosis, only genotype 1. We have 3 major targets: the protease inhibitors, NS5A inhibitors, and the polymerase inhibitors. The previous, the asvias, and the buvias. You will hear much about all these drugs at this meeting. I will talk on the efficacy on protease inhibitor-based triple therapy, including interferon ribavirin, and not the all-oral regimen. When I remind you to the first talk by Mark Thurs, he has elegantly shown you that the addition of the protease inhibitors gave us an advantage of curing hepatitis C by almost 30% in treatment-naive patients. Thomas Burke has elegantly shown you that the response to treatment with triple therapy very much depends how the patient responded to previous therapies. Very good results in relapses, very bad or inferior results in null responders, but still the addition of the protease inhibitor gives us certainly an advantage over previous dual therapy. So overall, we have to acknowledge that first-generation protease inhibitors give us a higher SVR rate for genotype 1 patients, and according to the response-guided treatment regimen, which differs a little bit between the 2 different drugs and areas of the world, we see shortening treatment duration. Now I would like to discuss and approach the problem of cirrhosis. These phase 3 trials that have been elegantly introduced to you have enrolled less than 10% cirrhotic patients. However, special patient populations are the real challenge for treating hepatitis C at the moment. And cirrhotics may be the most important group of these special patient populations, apart from the elderly, the HIV-HCV co-infection, and the liver transplant population. Why is this the case? Number 1, patients with liver cirrhosis have and are a danger to develop complications of liver disease. Encephalopathy, GI bleeding, jaundice, ascites, and above all, hepatocellular carcinoma. In particular, liver cirrhosis due to hepatitis C. Number 1 complication of liver cirrhosis is liver cancer. And this is also associated with a decreased survival. And what is very important, it's not only liver-related mortality. For still unknown reasons, we see not only increased liver-related mortality in patients with liver cirrhosis, but also all-case mortality. And this is a very interesting area of research, and this comes from data of a consortium of various centers in Europe and North America, headed by the Rotterdam Group and we had the privilege to take part in this analysis of patients with advanced fibrosis and cirrhosis. When we analyze cirrhotic patients, it's all about efficacy and safety. When we look at the results on phase 3 for both, for boceprevir and tenofovir, we see that the results for patients with advanced fibrosis and cirrhosis are inferior to those with F0, F2. However, as mentioned before, the number of patients with cirrhosis in these trials was limited, less or equal to 10%. In particular, we have a problem in patients with liver cirrhosis who previously had no response to dual therapy of pegylated interferon plus ribavirin, 14/10%. At EASL, the European Liver Meeting, the international liver congress in the world, we have seen very important data, as you heard in previous presentations. I will add to this series of very important new information. This is one of 2 phase 3 trials in treatment-naive patients, Quest 2, that was presented at EASL, and where cimeprevir, a second wave or second generation protease inhibitor, was used together with interferon and ribavirin. And it was interesting to see whether with the next generation protease inhibitor we see results and more results with cirrhosis. All these studies with interferon ribavirin had to exclude patients with thrombocytes below 90 or 100,000. So even if they included cirrhosis, they were well-compensated cirrhotic patients. And here you see the number of patients. You see that around 20% had either F3 or F4 in this series. And when we look at the results, we see that even with this next generation protease inhibitor, we see less efficacy in cirrhotic than in non-cirrhotic patients, but still a significant improvement over dual therapy. And in this phase 3 study, where I had the privilege to present on behalf of the investigators, we see that cimeprevir adds to dual therapy both in F3 and F4 advanced fibrosis as a significant parameter for SVR12. This brings us back to the retrospective analysis of the initial phase 3 and phase 2 studies. This has been done by pooling and analyzing various trials. This is, for example, a study with boceprevir, where a meta-analysis was done with 5 phase 3 clinical trials, and Dr. Phelan presented this as a poster and will be presented later this week in more detail as an oral presentation at our parcel. And I want to repeat here that again, with F3 and F4, this pooled data meta-analysis of 5 trials, you see inferior SVR rates in fibrosis, advanced, and cirrhosis compared to non-cirrhotic patients. What is interesting is that for those patients with cirrhosis, where the cost of treatment is high, and we come back to safety later on, where safety issues are more prominent, that we need to tell the patient as early as possible when he should not continue treatment. And Dr. Berg has explained to you that we look at different time points. And we have learned that treatment week 8, this is as an example, the boceprevir-based data, you see that after treatment week 8, if the patient is undetectable, there's a high SVR rate. While if he has less than 3 log decrease, there's no response at all with advanced fibrosis. So this is an important time point for patients with advanced fibrosis or cirrhosis in the light of the cost of treatment and the increased adverse event rate. This is here the multivariate logistic regression analysis demonstrating predictors of SVR in patients with advanced fibrosis and cirrhosis for this meta-analysis. And you see the high value of treatment week 8 undetectability to predict response. And when we look at the adverse events, we have to acknowledge that the safety profile looks reasonable. We have increased adverse events in cirrhotic patients, but still treatment is well tolerated. But one of the problems is that in these trials, only patients, as we mentioned before, with thrombocytes above 90 or 100,000 were included, so these were not really advanced cirrhotic patients. So the conclusion of this meta-analysis is that triple therapy is safe in this compensating cirrhotic patients, that the SVR rate is lower than in non-cirrhotic patients, but still reasonably good. I would like, in the second part of my talk, analyze with you patient cohorts that more reflect real life and real world concerning safety and efficacy in cirrhotic patients. Before concentrating on this issue, I would like to discuss with you the assessment of fibrosis. Because in the assessment of fibrosis, we are changing our approach. Biopsy has been the gold standard, but it's invasive. It has a risk. Patients do not accept biopsy as they did before, and the clinical utility has been questioned reasonably. And therefore, a lot of efforts have been done to include non-invasive measurements of advanced fibrosis and cirrhosis. And there is a very interesting program, the Telaprevir early access program, with more than 600 patients enrolled with F3, F4 cirrhosis. And here you see the methodology that was used, and you see that 80% of those patients, FibroScan was used instead of biopsy. I would like at the last part discuss with you three different cohorts, the French one, our own single center experience, and this early access program with Telaprevir. When we see at patient demographics, in the cubic this was 100% cirrhosis, while in the early access program with Telaprevir and in our, there was also F3. When we look at these patients' cohorts, it's very important that we individualize, look at the patient demographics. You see the high adverse SAE rate in the French population, the low one in the early access program. The reason is because here, according to the label, only patients above 90,000 were enrolled. Predictors of severe adverse events in the cubic trial were platelets below than 100,000, albumin below than 35, and this was confirmed in our single cohort study where we added Child-Pugh score of 5. So overall, the safety is poorer in advanced liver disease than in non-cirrhotic patients. This has extremely been demonstrated by the cubic study, which is here the first report, and you see the difference to the well-selected phase 3 patients. At EASL, some weeks ago, we had the privilege to look at the SVR12 data of cubic, and despite the high rate of SAEs, you see still good response rate. You still 50% in relapsers, 40 or 32 in partial responders, and the known low rates in null responders. Therefore, the individual selection of patients with advanced liver disease according to benefit risk is very important. And some words on our own patients, you see in our own cohort, 200 have been analyzed prospectively. 86% had F3, F4 fibrosis, and you see that 37% had severe anemia below 10 or even below 8.5. And reasons for hospitalization, apart from anemia, were infections and hepatic decompensation. And it's interesting that all patients with either SAE or treatment failure had either low thrombocyte levels or a Child-Pugh score of more than 5. So this may help in the future really to better select the patients with advanced fibrosis and cirrhosis for treatment. And this is again the risk factors out of the cubic study, where also low platelets and low albumin were analyzed as most important predictors of SAEs. So ladies and gentlemen, I would like to summarize. Number one, HCV protease inhibitor-based triple therapy increases SVR rates in cirrhotic and non-cirrhotic patients. SVR is reduced, in particular in previous null responders. There is limited experience in pivotal trials, and those with cirrhosis are not advanced because of the limitation of thrombocyte levels with 190,000. Increased rates of severe adverse events are seen in the real-world experience, like in the cubic trial. And therefore we need a careful individual benefit-risk assessment, in particular in treatment-experienced patients. We use nowadays ultrasound to predict and analyze complications. We use FibroScan in a majority of patients, as you have seen this. But that it is also worth analyzing and identifying patients that may profit from treatment is shown here. This is my last slide. Also the collaborative effort with the Rotterdam group. You see that if in patients with cirrhosis you are able to achieve an SVR, you can significantly decrease all-cause mortality, liver-related mortality, HCC, and liver failure. And finally, I thank you.